Alright, hello everyone, this is Joe Minardi, and I'm here to talk to you a little bit about some introductory echocardiography. Now this is primarily aimed at our students on our third year clerkship, but hopefully will be useful for anybody who wants to brush up or who's a little bit new to this concept of doing limited bedside echocardiography. So before we really jump in, I want to talk a little bit about why we care, why we're talking about this. When you're taking care of patients, I think we all know, you've heard many of your mentors maybe say, more information you can get, the better information you can get, the better you're going to be able to make a diagnosis, make a good differential, and make a good plan. So you'll always hear people like me saying, take a better history, do a better physical. And another thing you'll hear me say is, use ultrasound and echo when we're talking about the heart. Ultrasound is a relatively cheap, relatively easy, incredibly safe, very effective way to give you extra information to help you take better care of your patients. So, with that in mind, let's jump right into our topic here, 5 questions. So, first thing I'm going to do is tell you the 5 questions. So you've got a patient with a heart, and you take some pictures of that heart, and really, we're going to make it simple. Question number 1, is the heart beating? It doesn't get much easier than that. I think my 3-year-old can figure that out on most patients. Then next question, is there a pericardial effusion? And then we'll talk about, even beyond that, signs of tamponade. Then the next thing, is there left ventricular dysfunction? We'll talk about a couple of kind of general types of dysfunction you might see in the left ventricle. Then next, is there right ventricular strain or right ventricular dilation, really is what we're looking for. There's a few other things that go along with it, but that simplifies it for the most part. And then any obvious, and we'll talk about some really obvious things you can look for that are clues to obvious valvular or aortic root pathology, and when we care about those and when maybe we don't, when they're acute versus chronic. So those are the 5 questions. Write them down, remember them, commit them to memory, and go through those in your mind every time you're taking a look at some pictures of the heart. So indications, so we're talking about mostly you guys students on a third year clerkship, but later on in your practice, I want you to think about reasons you might do this, and then I'll talk about when to do it on a clerkship. You may do a limited bedside echocardiogram in somebody that's cardiac arrest, someone who's got signs of shock or hypotension, maybe someone with chest pain, shortness of breath, somebody with syncope or lightheadedness, dizziness, or maybe with palpitations. Some of these, it'll depend on your clinical scenario, it depends on what your differential diagnosis is, but in many of these cases, a limited bedside echocardiogram can give you extra information and again help you make a better differential, make a better decision, better plan. So an easy thing to remember, don't remember all those. If you're doing an EKG, think about doing a limited bedside echocardiogram. Now when you're on the clerkship, it's even easier. If you have a patient who has a heart, do an echo because it's going to help you get better at your skills. It's going to help you learn the anatomy better, learn how to do image acquisition a little bit better. There's some things it's important to know the limitations of the bedside echocardiogram and what you can and can't do. So there's some things you won't do. So that list there to your left, you will not rule out acute coronary syndrome or ischemia with a bedside echo. You will not rule out a pulmonary embolism. You will not rule out vegetations. You will not rule out aortic dissection. You're not going to quantify valvular pathology. You're not going to perform, at least what we're not going to talk about today, performing diastolic dysfunction measurements. You're not going to diagnose or fully delineate any complex congenital abnormalities, and you're not going to do estimations of filling pressure. So that's important. So if you go at a patient with the question of, are they having a heart attack or not, and you try to figure that out with a bedside echo, you are not going to exclude that diagnosis. You might get some information that makes that diagnosis more likely, but you are not going to rule that out. Important, remember that. So I like to repeat important points. So I think some of the most important points of what we're going to talk about are the 5 questions. So question number 1, is the heart beating? Number 2, is there pericardial effusion? Number 3, is there left ventricular failure or dysfunction? Number 4, is there right ventricular strain or dilation? And number 5, is there obvious, emphasize that word obvious, valvular or aortic root pathology? Alright, so a lot of you folks that are on the clerkship at the moment probably haven't even dealt with a lot of ultrasound or echocardiograms. So I'm going to give you a little bit of intro into just some basic anatomy and ultrasound technique. So the heart is not like a lot of structures in the body. It doesn't really lie in a sagittal or a coronal plane. It has its own kind of long and short axis. So long axis kind of runs from the right shoulder to the left hip, roughly, area. and short axis is pretty much opposite of that. Now when we do echocardiograms, we slice the heart into multiple different planes. We slice it along its long axis, which is kind of this blue plane here, its short axis along this yellow plane, and even its own kind of coronal axis in the 4-chamber view with this green plane here. And you'll see that. And really what makes the most sense of this is really just pattern recognition and repetition. Twisting your brain around and trying to wrap it around how you're viewing the heart is kind of difficult when you're beginning. So really recognize, when the probe goes here, this is what the image should look like roughly, and that is easier for you than trying to build this model in your brain at the beginning. The transducer that we're going to use for the most part is going to be a sector array or a phased array. It looks kind of like this. If you're using the handhelds, that's really your only choice, so it makes it easy. And our setting, this is important because everything we talk about is going to assume that you are in a cardiac or an echo setting. So make sure that that is the setting that your machine is set to when you're doing your echocardiograms. And make sure that this indicator is here on the right-hand side of your screen, which is particular to echocardiography. And again, is important because we're going to assume we're in that setting for all the anatomy that we talk about later on. The patient's going to be in either the supine or ideally the left lateral decubitus position if they're able to do that for most of the views that we're going to talk about. And we talked about that indicator and the presets, so this is why. In most other applications of ultrasound, we move our indicator over here to the left-hand side of the screen. However, in echocardiography, the indicator is over here to the right-hand side of the screen. And the importance of that is so when you place the indicator where we say we're going to ask you to place it, that you get images that look like what we're going to do on the screen. Now, as you get practice and familiar with this, it doesn't matter as much. But for everything we're going to do, assume we're in an echo setting or a cardiac setting, and our indicator is going to be on the right-hand side of the screen. And you'll see that, you'll recognize that here. Otherwise, you'll get right and left ventricles flipped and mixed up, and apexes will be on the wrong side, and it'll just make it a little bit harder for you if you don't pay attention to that. So we're going to talk about really 4 basic transthoracic views. In your third-year clerkship, you're not going to do transesophageal echo, not yet anyway. We're going to talk about the parasternal long and short axis views. We're going to talk about the apical 4-chamber view and a subxiphoid, sometimes called subcostal long axis view. So let's start with the parasternal long axis views and short axis views. And that's usually the first view that I like to do when I do a bedside echocardiogram. So long axis, we've got our patient here is lying flat. They could be in the left lateral decubitus position. And here's our probe. And notice how the operator, holds the probe down low and their hand is down touching the patient. That's very important. I'm going to talk about that some more later on. Our indicator is roughly directed towards the patient's right shoulder. I'll tell you, in most patients that you're going to see, it's actually probably directed right across their chest at almost 10 o'clock, even 9:30, because most patients' heart is almost horizontal in their chest. And so roughly there is where you're going to get your long axis view. You're in about the 3rd or 4th, maybe 5th intercostal space, right next to the sternum, almost touching the sternum. And usually what I do is I slide up and down the chest until I start to see the heart, and then I fine-tune my views. The best way to get short axis views is after you've identified your long axis view, rotate the probe clockwise around 90 degrees, and your indicator is going to be at about 1 o'clock, pointing, actually, usually it's somewhere up towards the patient's clavicle. So important, again, our students currently on the clerkship haven't done a lot of ultrasound, so I want you to realize, and you'll see this when we do some workshops, how you hold the probe and how you apply it to the patient's body is actually very important. It seems like a detail that's small, but it's very important and will make you a better scanner if you do it right. Choke up on the probe, hold it down right towards the end that touches the patient. Your hands should be on the patient. If your hands are not on the patient, you're going to have a lot more difficulty, especially with the heart. Your movements, once you get close and you start to see something beating on your screen, then your movements need to be very small and very fine-tuned. And I usually tell people when they're first just looking for a view, rotating the probe around doesn't help. Sliding it, sweeping it, or rocking it in certain directions may help you, but rotating it is usually going to get you more lost and help you less and hurt you more. So image interpretation skills, I think it's important as you're doing this to pay attention to normal anatomy, be systematic, kind of run through a checklist in your mind, and pay attention findings and the normal relationships of the heart and the anatomy are. And the more you recognize normal, the more normal makes sense to you, the more abnormal will be easier to recognize. So parasternal long axis, right? First view I like to do. So again, we kind of already talked about where we're going to put our probe, roughly the fourth intercostal space, indicator to about 9:30, 10 o'clock. And our hands are down low, they're touching the patient. We're going to slide up and down right next to the sternum until we start to see heart, and then we're going to fine tune. Short axis is wherever this was the best, rotated clockwise 90 degrees. And just to show what the anatomy looks like, I hardly ever get a patient with a heart this vertical. They're usually more like this, but okay, whatever. This is what it's going to look like on the screen. Apex is over here, base of the heart is here. We've got our left atrium, mitral valve, left ventricle, aortic valve, aortic root exiting the left ventricle, interventricular septum, little portion of the right ventricle, and we don't see anything else in the heart here. This is our left ventricular free wall, bright white pericardium wraps around. A couple more examples. Here it is with some labels and a nice diagram for you. These are images to burn into your brain so that you can recognize them when you see them on your patients. So after you've acquired, hopefully, a reasonable image, parasternal long axis view of the heart, then systematically pay attention to the pericardium. It shouldn't have any fluid in it. The left ventricle should change volume. It should decrease by at least 50% in a normal person, maybe a little bit more than that. The valve leaflets should be thin. So we can see here the mitral valve leaflets are thin. They're very mobile. Anterior leaflet slaps up against the septum almost during diastole. And take a look at the right ventricle, the aortic root, the left atrium. They're roughly equal in size in this view, so that's another important thing. Here we see descending aorta as well, wrapping around the back, and here's the vertebral body, the shadow behind it. Those are important landmarks we'll talk about later on. Like I said before, pattern recognition is very important, so I just wanted to show a couple more views of the parasternal long axis heart. So remember, apex is here, the base of the heart is over here. We've got our left atrium, mitral valve, left ventricle, exiting the aortic outflow tract, aortic valve, aortic root, interventricular septum. Right ventricle is here. You see right ventricle. Right ventricle is almost always going to be one of the closest things to your probe face right here. So that will help you identify that. Bright white pericardium, the left ventricular free wall down here, descending aorta. I hope you see and recognize all those structures here. Pay attention again to the fact that the left atrium, aortic root, right ventricle, roughly same size. All right, parasternal short axis. So to get our short axis views, we slice multiple planes. We've rotated our probe 90 degrees clockwise after identifying our parasternal long axis view, and we're going to talk about mainly just a couple of these views, but to kind of show you, here's what we're doing. We're slicing the heart along its short axis, and we're focusing on the left ventricle. We're trying to make it look pretty circular, and we'll see portions of the right ventricle as well. And this is a little graphic I borrowed from our folks at Sonographic, which I think, again, just helps illustrate what we're doing and what the anatomy looks like. So we'll take their skin away. We see we've got our probe here slicing through the chest, trying to identify portions of the heart. Let's just get a little bit closer, take a look at what we're doing. The heart is lying kind of in this long axis. We're slicing it along its short axis. So here's one of the initial views. So here we're slicing close to the sternum at the base of the heart. Here's a diagram showing you what it looks like. And we're focused here on the aortic valve, which is pretty central. It's got a pretty bright white border around it. Left atrium is right here. Over here we see a little hint of the tricuspid valve, so that would mean right atrium is here. Right heart wraps over top, right ventricle again, closest to our probe. And the pulmonic valve is almost visible over here. And so here we're slicing. We've just moved slightly away from the sternum, and we're slicing out more towards the mitral valve, so we get sometimes called the fish mouth view. The left ventricle looks pretty much circular. Right heart structures sit here, a bit of the descending aorta down here. And now we're again moving away from the sternum to about the mid portion of the left ventricle, and we can see it looks nice and circular. We see papillary muscles here now. Bright white pericardium wraps around, right heart structures here, and we can take note of pretty symmetric thickening, pretty good volume change going on in this left ventricle. So when you do these short axis views, again, go through your checklist of normal findings. The pericardium, it should be empty. The left ventricle should look pretty round. The thickening should be pretty uniform, and the right ventricle should be small, especially once you get down to that mid-ventricle. You shouldn't notice a big prominent right ventricle. If you do, then you got to think about, is there something wrong with it? And then if you keep slicing down, you may get views, cross-sections of the left ventricular apex, nice and circular, symmetric thickening, and now the right ventricle is pretty much, we've gone all the way past the end of the right ventricular apex. Alright, so next up is our apical 4-chamber view. So here, now I'm going to say this, it's important to get as low and lateral as possible, usually to get your best views, the apical 4-chamber view of the heart. So we continue rotating a little bit more clockwise, so now our indicator is directed at about 2 o'clock, 2:30, and we're at about the 6th or 7th intercostal space in the anterior axillary line on the patient's left side, and even better if they're up on their left lateral position with their arm up out of the way. And we're directing that ultrasound beam towards their scapula on the right side, trying to get this view of the heart. Most important thing to notice about this is that if you're doing it properly, left heart over here, right heart over here. Interventricular septum is usually pretty visible right there in the middle, and then we'll see left atrium, mitral valve, left ventricle, right atrium, tricuspid valve, right ventricle. And the left ventricle should be larger than the right. Volume should change, roughly decrease by about 50%. And we'll also notice that the tricuspid valve is a little bit closer to the apex than the mitral valve is on the left side. And when you can see this right ventricular free wall pretty well, you can notice that it's thinner than the free wall of the left ventricle. Depends on how well you see it. And this is just, again, conceptual help from our colleagues at Sonographic again. We'll move the skin so we see we've got our ultrasound beam slicing along the coronal axis of the heart. That beam is going up towards their right scapula. We'll take their ribs out of the way, and so you see kind of how we're slicing it, and then we're flipping that up onto our screen. And this is what hopefully we see. So this portion of the probe has been flipped up to here. Left heart, right heart. Again, pattern recognition. Left heart here, right heart here. Notice that the tricuspid valve a little closer to the apex compared to the mitral valve. Again, go through that checklist. Pericardium should be empty. Look at the relative chamber sizes and thicknesses. Look at the change in volume. And notice again those valve leaflets. They should be thin, they should be nice and mobile. And I just show you this. We're not going to talk about this a whole bunch for our purposes, but often you'll see this even by accident as you fan the transducer a little bit off of the chest. You'll start to see the aortic outflow tract right here in the middle. And this is just sometimes called the apical 5-chamber view, with the aortic outflow tract being the 5th chamber. And we can see a diagram of that over here. This is a useful view that we use for other purposes, but for what we're talking about now, we're not going to talk about it too much, except for you, just to help you recognize it when you see it by accident. Alright, the last view. Now this view you might have heard of in the FAST exam or seen in the FAST exam before, probably even in your first or second year. This is the subcostal or the subxiphoid long axis view. When you do this in the FAST exam with an abdominal setting, your indicator is usually directed in this direction towards the patient's right, but here in our cardiac or echo presetting, our indicator is going to be directed towards the patient's left. And we've got this down underneath the xiphoid process, and you can see we really have to compress into their abdomen a little bit, and we're shooting our beam up towards their C-spine almost to get views of the heart in its long axis. And you'll see liver here, and again, closest to your probe is going to be the right side of the heart. So here's right ventricle, right atrium, tricuspid valve, interventricular septum, left ventricle, left atrium, right white pericardium surrounding. Shouldn't have any fluid in it. And here are some actual moving pictures. Left ventricle here, closest to the probe, right ventricle, right atrium. We've been seeing a little bit of the aortic valve here, depending on how we slice. Left atrium, mitral valve, pericardium, take note. Doesn't have any fluid in it. Note the liver right here. That will help you recognize this. Now, one of the important things is to notice in this view, we've got the apex on this side of the screen, and the base of the heart is on this side of the screen. That's one big difference from some of the other views we've looked at. And again, go through your checklist. Pericardium, it looks empty. Look at the relative chamber sizes. Look at the volume change in the left ventricle. All things to pay attention to. Recognize normal. Teach your brain to recognize normal so that when abnormal's there, it stands out. All right, those are the views we're going to do. Those are the ones we're going to talk about. So let's go back to those questions. Question 1, heart beating. Just take a poll. What do you guys think about this one? Is it beating? You think about that. Pericardial effusion. Yes or no? Is there left ventricular dysfunction? Is there right ventricular dilation, which may indicate strain? And is there obvious valvular or aortic root pathology? You see how if you recognize all those normal things we talked about, hopefully as we talk about abnormal, those things will stand out.